Well, good morning and welcome for those of you who are joining us virtually. And this is the University of Virginia School of Continuing Professional Studies under the Center for Public Safety and Justice. We have our Public Safety Speaker Series, and this morning, session 8, I should say for us, is around mental health and crisis intervention in public safety. During our hour, and the hour always goes by so fast, we're going to be looking at mental health responses for public safety. And we also want to talk about things that we have been, I would say, not necessarily talking about for a while, but are very understandable for those of us on the screen, and focusing on issues of crisis intervention, the partnerships with mental health professionals, and de-escalation. And when I talk about mental health responses within public safety, I also want to make sure that we are talking about officers as well. Oftentimes when we talk about that, we are outward focused and we're not looking inward. So we'll have a little bit of conversation around that. Today's panel is incredible. I would say they made the mistake of answering the phone when I called, or the text, but they are just incredible folks to have on this conversation today. I'm not going to introduce them. I'm going to ask our lovely background moderator to drop the bios in the link for you all to look at. Some of the faces may seem familiar to you, and I'm going to tell you they certainly are. And one of the things I want to do for my panelists is this is going to be a conversation. Although I'll have questions directed towards you all, I want to make sure that you are adding in where you want to add in. And then if you want to, as we say, you want to pass that, you can definitely pass it to someone else. But what I want to make sure is that this feels comfortable for everyone and for our viewers as well. So let me start by setting the stage just a little bit. One of the things that most of us have experienced on this screen with our public safety backgrounds is the need for mental health and mental health responses. They've changed significantly since I think a lot of us were in uniform. We have multiple iterations today, but we also want to talk about not just what is working, but what does the future look like? But in order to do that, I really want to sort of set the stage. And I'm going to ask, and I'm actually going to direct this towards Richard and Pinkey. And I want to get your idea of what is sort of the state of mental health today. And when I say that, what is happening in this space? We know that historically there were never enough beds. We were always talking about sort of innovative ways to interact. But can you give me a little bit on what is the state of mental health today? And Pinky, I'll start with you, and then Richard will move directly to you.
All right. All right. Well, good morning, everyone. Our audience, I can't see, but good morning to you as well. My background is in healthcare. I am retired from Kaiser Foundation Health Plan of Colorado. What I have been seeing with regard to mental health in communities today is that there is a significant increase in demand. That is the first thing. And then also that there are clear inequities in service provisions, access to care all across the country, not just in one specific place. There is also still, I think, a lot of stigma associated with receiving mental health treatment. I know that there's been a significant rise in suicide rates as well. Financial constraints, the list goes on and on and on. I don't want to go too far with what we are lacking, but there have been also some improvements in the delivery of how healthcare organizations are ramping up what they need to do to care for their patients. And I'm sure we'll get into that discussion as we move further along. So I'll defer to the doctor at this point.
Richard, please go ahead.
Thanks so much, and good afternoon, everybody. I want to preface my remarks by saying I'm sitting here in the District of Columbia. I am now Senior Director of Behavioral Health for Unity Healthcare, the district's largest primary care provider, and I'm really pleased to be there and doing the work of centering mental health in primary care. But I spent many, many years in the district's public behavioral health system, including 5 years at the DC Department of Behavioral Health. I am I took my Unity background off because I want my comments to reflect my own views, and I will try not to veer too far off. But it is distressing to sit here in the District of Columbia right now where it feels like there is a move to recriminalize rather than decriminalize mental illness and homelessness. I know many folks are aware of the federal presence currently on the streets of the District of Columbia. People may not be as aware of the accelerated federal homelessness DC clear out. Unity Healthcare, in addition to providing services in the community to including all of the low barrier shelters and traditional health centers, provides comprehensive health services at the DC Department of Corrections. And we're trying to keep our eyes on what the uptick is in arrests for people who are refusing to go to shelter. So this conversation is timely. I agree with Pinkey that there are some very progressive things that have happened in the last number of years, especially in crisis care, and I'm looking forward to the panel discussion about that. When I was at the Department of Behavioral Health, I was the first ever chief of crisis services, and felt very good about the work that we did to move away from an automatic law enforcement response to crisis. But again, I'm worried about the impact of Medicaid changes that are in the offing and how that will change access. So it's I come to this conversation, I think there's cause for hope, but also reason to be very sobered about where we are.
Thank you for that, Richard, and that reminder that we have folks that will be needing those services and may not be able to access them. And I think that is, not just your concern, but everyone's, including those in public safety. My next question is for Paul and RaShall. And Sylvia, I'm not leaving you out because I got something special for you. One of the things that we talk about when we are talking not just about the response of law enforcement, but the types of things agencies and organizations are involved in regards to the approach of mental health. And I'll start with you, Paul, because not just because you're Denver and you and I are longtime friends, but you and both RaShall, and same with Doc there, you also have that experience of needing to have a different response that has historically been given when somebody's in mental health crisis. And Paul, I'll start with you, and then we'll switch over to Doc Brackney.
Keesee, thank you very much. I'll try to keep it brief. It's a little bit of an evolution, but really the epiphany was realizing that some of our previous approaches weren't working. Many of our early efforts in coming up with alternative response, co-responder models, as well as support and services after that crisis, began in 2014 in a neighborhood that Dr. Keesee knows well, the Sun Valley neighborhood. It was the poorest neighborhood in the state of Colorado, and it also had the distinction of having the highest rates of mental health challenges. And typically we would see grants come in, people would provide some sort of service for a couple of years, and then they would leave, but we still had the same challenges. So in 2014, we applied for and received a Byrne Criminal Justice Innovation Grant, and innovation, part of it was key. We then used community-based outreach to help us identify and support not only individuals that were dealing with mental health challenges, but the families. We created a family support system for parents with children. It continues today, which is great. But that was one of the early steps that said, hey, what we've been doing for decades isn't working. That led to co-responder models. Co-responder model led to the STAR team in Denver. We also realized that the call goes far beyond that initial response, and we created some outreach case coordinators to do the follow-up work, as well as finally an assessment intake diversion that could do real-time when people are in need, be given the support that they need with wraparound services.
Thank you for that. I appreciate it. We lost you just for a minute, but we didn't lose audio. Just so you know, we heard everything that you said. So I appreciate that. Doc Brackney.
So what's interesting about it is that my early career in Pittsburgh, we realized early on when they started closing the state funded hospitals for mental health and support that we would need to shift our model. So very early in the early 2000s, Pittsburgh switched to a model in which they had partnered with UPMC, which is the largest medical provider in the Pennsylvania area, to create this resolve or crisis resolve responder model very early on. However, we realized that that wasn't going to work to the degree that we thought. Again, issues around beds being available, what happens when you introduce a law enforcement professional into a mental health or crisis mode when they're just not equipped. And we know statistically, when you leverage 911, when someone is in a mental health crisis, the determinants, the negative outcomes of that, particularly for Black men or men who are trans, it's going to be deadly for them, right? So we know right away that this is going to be a problem. So you have to shift the way in which we've approached this. And one of the ways that was really creative and innovative in Pittsburgh that we used, and then I used in Charlottesville, is starting to use asset mapping. What were those resources that were in the community that could address the problem, that removed policing and public safety from the problem? And when you do that, you don't have to rely on government, the cutting of Medicare or Medicaid, but more importantly, we're not trained to do that, right? We focus a lot, and I know we'll talk about this, on de-escalation and making the responsibility on the person who we're encountering to de-escalate, never on the officer not to escalate, right? So the lens is always focused in the wrong direction. And when you do it that way, you miss the opportunities to provide creative care for people who are in crises. And again, I'm really concerned about what's going on across the nation, where we're criminalizing poverty, we're criminalizing mental health, we're criminalizing the disenfranchised, and those age ones, and we're going to start using, again, the criminal legal system to treat mental health, or supposedly treat mental health, because it is the catch basin of all services when no other services exist, or when we're not interested in those kind of services. Just my thoughts on that briefly.
And I appreciate that. And thank you. You also did a really good handoff to Sylvia when we talk about issues of de-escalation, but more so, Sylvia, around officer preparedness, right? So we know that there are programs like CIT. We know that there are the co-responder models like Paul was just talking about. But we also know that officers are carrying their own trauma when they step into those situations as well. And we'll get to that in a little bit. But can you talk to us about officer preparedness for, as being the undersheriff? What are we looking at when we are talking about being truly prepared? And please feel free to add on to the kinds of responses that you see that may be different.
Well, thank you for that. Look, all of us have recognized that the police are not the right and appropriate societal actor to handle the issues that are laid at our feet. So what we did was we started examining how the officer engages with self and then self with others. A really important piece, this kind of double lane piece that we travel, is that the recognition that de-escalation is not a singular noun. Rather, it's a philosophy and perspective that highlights an officer's capacity for analytical thought, their personal wellness, their empathy, their emotional intelligence, their communication, their confidence, competence, defensive tactics, and how they engage in these evolving situations. We tend to approach this from a training perspective and to couple the training of mindfulness as a way of engaging in the very difficult issues that officers engage in. This practice, I'm going to kind of highlight this. This practice really starts with neuroscience and recognizing that we are human beings that often escalate events where they don't need to be escalated. We tend to amplify events in terms of their urgency for resolution and time, where they don't need to be urgently handled. So a practice that recognizes the individual human being police officer that is engaging has been found to be incredibly successful. That is, meditation is one of those pathways. It is recognizing mindfulness, and officers have been reporting that they are less reactive and more responsive with these really critical unfolding experiences. Further, that coupled with the tactics of de-escalation, CIT, has been found to be really successful for the individual officer and the successful outcomes for the populations that we serve. We can put some finer points on this later, but I think that is a place for us to start itself, looking at self-engaging, and then how that extends outward. And I look forward to describing that with greater detail as we move on.
Absolutely. And thank you, because you are lifting up a new area in which we find organizations really needing to pay attention, and that is how the individual officers themselves are showing up and managing, right? So we're really talking about self-control, and I like the de-escalation is not a singular noun. That's a t-shirt, Sylvia. So I just want to let you know on that one. And I appreciate that. And we absolutely have to start thinking about it. Richard, I want to go back to you. And we are talking about not just mental health needs, and you heard Pinkey and both RaShall mention it, but let's just shift just quickly to partnerships, right? So RaShall says, who's in the neighborhood, because oftentimes they're very, any other organizations might be overwhelmed with it. Can you talk to us about the partnerships and the importance of those partnerships when it comes to a mental health response or even a mental health conversation?
Yeah, thanks. So it gives me an opportunity. Actually, I took a peek. I know that Ben Heyman from the UVA Center is listening in. The Department of Behavioral Health and the Metropolitan Police Department in the District of Columbia, along with Fire and EMS, our 911 service, partnered incredibly well. In a number of ways. The partnership certainly extends backwards a number of years, and then grew and strengthened a number of ways after George Floyd and Black Lives Matter and so forth. But in the District of Columbia, the Department of Behavioral Health and MPD have for many years done a voluntary crisis intervention officer training, which is it differs a little bit, but not substantially from the international CIT model. One of the things that we did was the mayor made a very public commitment to having all officers on the street trained in crisis intervention officer training or mental health first aid for first responders. And we hit something like 99%. By the end of 2023. We also partnered and traveled. One of the things in terms of the partnership, we did develop a co-response program. We, with Fire and EMS and the 911 Center, we developed a 911 behavioral health call diversion program. One of the things that happened was that we did training and visits together. Leadership visited Harris County and Houston. We went together to the CIT conference in Pittsburgh a couple of years ago and had a full day intensive with Margie Balfour and her team from New Mexico, or from Arizona. We did tactical training together. The co-response teams went through training together also with the William James College folks. Our mayor and chief and our director of behavioral health went to Denver to visit, to look at what was happening there. So those were the governmental partnerships, though, Tracie. I'd like to also just comment about the amount of work that we did with advisory neighborhood commissioners and community meetings to talk about the District of Columbia has long had a clinician-only mobile crisis team as well. So we really tried to educate the public extensively on all of those alternatives so that there would be a no wrong door kind of approach. If they called 911 and it didn't really, there wasn't an immediate sort of threat of danger, that those calls could get diverted to our mobile response team. So I think, again, those partnerships are critical, and blending, especially with respect to the co-response program, blending those, they're very, very different cultures that people are coming from. The joint training, I think, was one of the critical things that we did.
Thank you for that. And I'm going to, Paul, because there was a wonderful sort of segue to you as well, in regards to the program that you put in place in Denver. But can you talk to us too? I know that it has its successes, but what are some of the barriers that are still existing, right? Especially when you talk about sustainability and scalability. Can you talk about that a little bit?
Well, hopefully there we go. The audio continues here. I think the key word in this is partnerships, but partnerships are not always easy, particularly when there's a competition for scarce resources. We have many needs, and all of these needs require funding. And sometimes that is the barrier that separates the grand ideas that we may have of providing better help to those in need, to provide better service to individuals in crisis. And so oftentimes you have folks that want to build their own empires, to include police departments and law enforcement agencies, where they start providing service that goes beyond their needs. The key to all of this is really focusing on what that North Star, and the North Star should be better outcomes for individuals in crisis. If everybody can agree on the goal, then regardless of what the position is, you can work to achieve that. And I'm very proud of the efforts. We worked with many community groups, some community groups that were not very fond of our agency or city government in general, but we were able to set aside the differences, focus on that North Star, that common goal, and that is what has really helped for the sustainability. And really, lastly, it's success, right? If you're able to, for lack of a better term, pilot something and show that it works, then typically success breeds future success. And that was very helpful for us that we launched the STAR program in 2020. We did this not as an outside push, but from the inside, recognizing the need. And then the data and the statistics backed up the positive outcomes that we've had, and that has now grown to something I'm very proud of: 7 days a week, 24-hour-a-day coverage in every corner of the city.
Thank
Tracie,
you for that.
if I could just
Please.
echo
Yeah, go ahead.
the one thing that Paul said about the North Star. When we went into the launch of the co-response, there was a desire among some to quantify the number of hours saved in terms of officer time on the street and so forth. And there were also often people who framed it in terms of reducing or eliminating bad outcomes. For us to talk about good outcomes and quality care and the right response at the right time from the right responder really helped us not to get distracted and to sort of look at it in terms of the long term. I neglected, when talking about partnerships, to talk about our Medicaid authority. they traveled with us to Pittsburgh, and they traveled with us to Houston and Harris County as well, to look at ways to fund some of the mental health services that were wrapped into the crisis response and co-response as a strategy for making it more sustainable. We launched with COVID, American Recovery Act dollars and so forth, but needed to find ways to sustain that. It was never going to be self-sustaining on Medicaid alone, but that was another part of the partnership.
Thank you again.
Dr. Keesee.
Yeah, go ahead. Pinkey, go ahead. Right ahead.
Okay, yes. I just wanted to add a different perspective regarding partnerships inside of some of our healthcare organizations. I know that they have made a concerted effort to train primary care doctors and other clinicians across their programs to be able to identify patients that are having some type of mental health crisis. They're not always able to provide the care, but they have been given some limited training to help identify and refer those patients on to a place where they can receive care. So I just wanted to add that.
Dr. C, I think this is really, when we're talking about partnerships, and Chief Moir might be able to also speak to this. Here's the interesting thing about it. It's great that we have these partnerships, but do you notice what's so interesting about it? Each one of the models is still linking it with law enforcement, right? So that's the problem. No matter what the model is, until we address legislatively, in most places, the police are required to be that person who responds to serve the protective, the emergency custody order, or the temporary custody order, or in Pennsylvania, it's the 302, the involuntary commitment order. So if the barrier is always going to be, it's legislatively, when the default is in the law that the police or law enforcement is the responder, you're always going to have these difficulties decoupling this military law enforcement police response to a behavioral crisis moment. Does that make sense? So we can have all the conversations we want and try and create creative solutions. Until we are serious about decoupling that in the law, we're going to have a lot of these same instances over and over when we're trying to do a workaround for these instances versus authentic creating systems that support the needs of the communities that we serve. So, sorry about that for jumping in there.
No. I mean, this is our conversation, right? And Sylvia, your head is shaking, so I'm coming to you next as well. But I mean, you're lifting a long conversation, a long-held conversation in law enforcement, right? What is the appropriate response? And communities, depending on community and how that's defined, a lot still believe that you need to have that specific gun and badge there in case it goes wrong. But I understand what you're saying in regards to really getting to the causes and the sort of groundwork, and making sure that upfront or prevention is really done in a way in which you shouldn't have to call anyone other than your doctor, if possible, if you have a doctor. But Sylvia, please go ahead, because I see you you're nodding the head there in regards to a response. But talk a little bit about, because I know you've done a lot of work here too. So talk a little bit about what are those responses offer and not offer, and it sort of adds back into the question about barriers. But also, there are things that are happening on the horizon that show promise. And I think Dr. B, it gets to your, how do we prevent? So Sylvia, please go ahead. I can't hear you unless it's me. Are you on mute?
So how's that? So this is why we answer the phone when you call us, Dr. Keesee, because we get to be really illuminated by Dr. Brackney and everyone on this panel. This is extraordinary. And I hope that listeners pull out these threads, because what Dr. Brackney is talking about is this long-term strategy. To change legislation takes a long time. Here's one of the things that we love, and it's also excruciatingly difficult about policing broadly. We go in to fix things. We want to make things better. So we insert ourselves into these places where we are not the right and appropriate societal actor. I do want to highlight this very important piece, is that often the funding for police, sheriffs, that is the last to go. So it's appropriate that we're at the table in some instances. It also, there's growing evidence that there are improved outcomes when a trained officer goes to a call for service in this co-response model. There is evidence that there are improved outcomes, but what we're saying is that those calls for service involving folks suffering from a mental health crisis, addiction, all of the things that we are exploring in this webinar, it is often appropriate for that call for service to go to someone first other than the police. That is a massive shift in policing broadly. One thing that I bring to this conversation also is I've now served as an undersheriff for 3 years after serving 34 in municipal policing. That's given me a perspective about local jails and the folks that we are serving in local jails. And we can speak to that because 15% of men and 31% of women, it's reported, that are in our jails have some kind of mental health concern, an issue that needs to be addressed. And even 20 to 30% of those folks are found to be incompetent to stand trial. Now, those numbers signal something for all of us about the enormity of the issue and where folks are being served, right? And we can talk about that. I think what we have to address is that legislation is important, it is slow moving, and to have the right co-response model and properly trained police officers, deputy sheriffs, can really increase the positive outcomes, and positive outcomes really breed trust between the police and the communities that we serve. So I think Dr. Brackney really touched on something that we need to pay attention to.
And thank you for that. And thank you for your response as well. Richard, I see you're off mic. Give me just a quick sec. I want Richard to respond, but then I also want to move into something, Sylvia, you mentioned about building trust, right? Because that's a word that's thrown around quite a bit. And we haven't seemed to, figure out what does that truly mean. Richard, please go ahead if you're responding to Sylvia, and then we'll get into the next one.
Just very quickly about the data. I got some data from recent testimony from MPD before the Council Committee on Justice and Public Safety. 3,500 requests to our co-response program here in the district resulted in 1,800 interactions with people with behavioral health crisis kinds of things. More than half of them resolved on scene. Of those 1,800 interactions, there were 5 uses of force, only 2 of which were by the co-response specialized trained officers. 3 were from officers that were also responding to the scene. And the arrest rates are cut in half. So I think that, again, that's not to disagree with what the long game is in terms of what Dr. B was saying, but I do think that these intermediate gains are important and life-saving.
Oh, absolutely. Right. So anywhere along the line to the North Star that is doing it in a positive direction, I think is always going to be not just welcomed, but hopefully, to your point, replicated and funded. Pinkey, I'm going to turn to you really quick because I saw your head nodding there when Sylvia was talking about those who are incarcerated. And we have to talk about access, right? Who has access, who doesn't? And Doc, I see your head is nodding as well. But one of the things that we struggle with is how do we ensure that those who are in most need do get that kind of response that Richard's pointed out and then Sylvia's pointed out and as well as Doc B. And Paul, you mentioned this as well, right? And when you talked about the neighborhood in which you started, where the rates of mental health issues were high, which indicates there's other social determinants happening that are not law enforcement related. Pinkey, I'm going to go back to you. Talk to us a little bit about when we say access, right? Because we know communities, specifically communities of color, do not respond to necessarily services. So please go ahead.
Okay. Yes. I was nodding my head because that is monumental. The information that Dr. Richard shared there is incredibly important for us to understand. When we talk about incarceration, And the numbers that you heard, more than half of the individuals that are incarcerated have mental health issues. The penal system does not offer that type of care for those individuals that are incarcerated. You also have to think about continued trauma when you are talking about a person that is incarcerated. You have their family. Some of them have children. Those children grow up with whatever trauma that came out of that experience for them. Maybe they go on to use drugs as a result of the trauma that they experience. Maybe they go on to abuse alcohol. But also, with regard to incarceration, many individuals that are released from prison, once they're released, they still are not connected to any type of mental health treatment once they are out. Also, the struggle to assimilate back into society, the opportunity to get a job. There are so many things that are limiting once a person has been incarcerated. And then, as you stated, there are also these other socioeconomic impacts in our community. There's the issue of health disparities. When people of color show up into treatment spaces, we're not necessarily always given the appropriate care. When we start to talk about mental health and going in, the majority of treatment for people of color oftentimes occur in emergency departments. They're not in a therapist's office or anything like that. When they're in an emergency department, they're more likely to be restrained. They're more likely to be sedated when they go into those environments. And so it creates a barrier for people to want to show up to get care. So I think the issue of incarceration is a really, really big one. And as we're aware, our penal system is probably one of the largest in the world.
Thank you for that, Pinkey, and I appreciate you too. The cultural differences of how we not only approach it, but how it is responded to is also to be lifted up. Paul, I'm going to turn to you as well, and RaShall, this is for you as well. Let's turn inside to law enforcement itself, right? So the external conversation around community, which is important, but equally as important, as Sylvia pointed out, are the actors involved themselves. Paul, can you talk to us a little bit? And then I'm going to go to RaShall and then Sylvia. This one's for you because I want to hear a little bit more about the mindfulness piece that you're talking about. But Paul, can you talk about what you thought about for officers who are showing up to these calls, who themselves are also carrying traumas that they often either have, suppressed or have not even thought about, but can often be triggered. Can you talk about a little bit of how you sort of focused on that?
Well, I'm going to piggyback a little bit on what Sylvia started there. It's critically important to recognize that there are people that are involved in this, and that's people that are in crisis and people who are responding, whether that's law enforcement, EMS personnel. They are humans. They are people that bring the same set of challenges that all of us face. Oftentimes, law enforcement sees some pretty ugly sides of society. They're exposed to trauma at very high levels, and it's incumbent on the department, the leadership of the department, to try to provide support for its officers, particularly when they're involved in critical incidents or situations that are very difficult. So many departments have started wellness programs, which is very helpful. We have certainly done that, and we're early adopters of a pretty robust wellness program. But very specific to trauma, we did an entire reintegration program as well. And this would take officers offline. It would connect them to psychological services, to dietary services, physical activity. It was a whole 8-week program, and then slowly reintegrate officers because, again, as Sylvia said, officers are showing up to these same calls with the baggage of trauma with them. So all of us need to make sure that we're doing everything possible. If we, again, keep referring to that North Star, it's a two-sided coin. It's not just the individual in crisis. It's the EMS personnel, the alternative response folks that are showing up, and the officers. And we have to do everything possible to break down those obstacles for success in resolving those crisis calls.
Thank you, Paul RaShall.
Yeah, you're exactly right. So I think the thing is how do we recenter our officers, right? There are a lot of programs out there now, the Valor, that get to the why of why they're doing this work. There's programs, Blue Courage, that help people with heart-focused leadership and things of that nature. The thing I would suggest is this, is the lack of formal diagnoses or assessments for officers, right? And even for the population. I literally moved a certain amount of my budget when I was in Charlottesville. I took it from the training budget or travel budget and things like that to keep on staff a retainer for a police psychiatrist, specifically trained in what does public safety trauma look like. And then the officers, just for those who don't know or don't listen, the officers don't trust your health and wellness that comes from your employee assistance program. They don't trust HR or any of those. They are very skeptical. So moving aside that money where officers could just go on their own, and all I was provided with was a reference or code number that someone had used those services. Completely anonymous, and their ability to get help and services. Because the lack of diagnosis is just as concerning as a formal diagnosis and not knowing. There are a lot of officers who are walking around with post-traumatic stress symptoms, but no diagnoses of, post-traumatic stress diagnoses. So there's that part. The other part is we often just focus on either the psychological or either the physical well-being of officers. We don't talk about their full capacity to be whole and well financially. They're coming with a lot of stress financially, high rates of alcohol and drug use, divorce, a lot of issues around family life. So I focused on what does an authentic wellness, looking at their physical, financial, psychological, as well as their spiritual and emotional health, and then added another component. How do we have officers go through a formal assessment of where they are? We do it when they hire them, but we don't do it after they've been on 5, 10, 15 years to see how they've been impacted. And are they experiencing trauma they don't recognize? There's a lot of studies out there about high functioning people who are suffering from depression and don't know it. They're just high functioning. And you can imagine that police and public safety personnel are right up there, right up there.
Thank you for that. Sylvia, I'm going to go back to you. As always, you all are doing these incredible sort of handoffs, right? So when you're talking about the need for officers to understand mindfulness, and also to be able to be self-aware with emotional intelligence, can you talk to us a little bit about how those things are implemented or folded in? Because, I do both. I teach mindfulness and yoga, but I also know that officers think that that is like as they would say, it's like hippy dippy stuff. Why are we doing this? And this has got nothing to do with policing, right? But we know once they get to the other side, they understand the importance of it. So please.
Well, look, it might be hippy dippy, it might be interesting. It is absolutely essential as a human being, as a police officer, deputy sheriff. It makes us more tactically sound and technically proficient. The training proves, and there's research that is supporting this assertion. It proves that officers that practice mindfulness, which is in essence a consciousness, an awareness free of judgment for the unfolding experience. How is that not tactically sound? How is that not inserting humanity for this unfolding experience and interaction between a police officer and a member of the community? And I would say that when I started this as a younger police chief, much younger police chief, I started really engaging with meditation as a pathway to mindfulness and this training to interrupt, to influence. And people thought I was bonkers. But what they started reporting, police officers and professional staff started reporting, is that they were less reactive. They were more aware. They let the experience unfold. Our tacticians started reporting that in the environment of tactics, they were more situationally aware to the behaviors. They were more patient with the unfolding experience, and that they were more aware of the macro, micro terrain in the situation, in the environment in which they were operating. And if officers are reporting that, then how can we say that it is not the right thing for building trust, for improved outcomes, for officer safety? They're also reporting, and I'll add this, they're reporting that they were able to reset between calls for service. They weren't taking the trauma and difficulty of a past call for service to the next call for service. They had a reset, and they were saying this. They were saying that they were able to reset at the end of their shift before they entered their life as they walked in the door. And if that is not compelling for all of us, then what is?
Mm-hmm.
Thank you for that. I do appreciate it. And this is a part of what we need to learn about what is on the horizon and which things make those responses much better. As always, I'm paying attention to time, and I want to move to a couple of questions that are in the Q&A for us to answer before I get any last thoughts from you. The first one, I'm just going to voice over. I don't know if we can do too much with it because, Richard, you mentioned this, right? So the anonymous person says, I do medical billing for EMS agencies. What, if anything, can we do to ensure that individuals experiencing mental health emergencies receive coverage for EMS transport, especially those on Medicaid and Medicare, as these claims are typically deemed to be the most medically necessary? And it's certainly not lifting that up for you, Richard, but only mentioning that you mentioned that that is another thing on the horizon that we're going to have to really be paired and looking at. So I'm going to go on to the next one, is from Marie. One of the biggest gaps I've seen is more about the continual follow-up and who takes ownership of that once someone gets partnered with resources. Any suggestions on bridging the gap? And Paul, only because you're nodding your head yes, that's how I work. Go ahead and take that one for us. Anybody else who would like to jump in on that as well?
So thank you so much. You know, you have to begin with the end in mind, and I'm going to wrap it or speak quickly through this. Co-responders are one part of the response, and they have their place. What we have with the STAR program, the alternative response, where there's no police officer whatsoever, they have their place, low-level, nonviolent responses for individuals in crisis. And whether Paul is in crisis and I have a weapon and I'm causing harm and a co-responder shows up, de-escalates the situation, or Paul is nonviolent and the STAR van shows up and de-escalates the situation, that is great. High-fiving that we de-escalated a situation. But what about Paul tomorrow? What about Paul next week? What about Paul next month? And again, one approach that we took was 30 days after we started the STAR program, we already had the robust co-responders. We have outreach case coordinators, caseworkers, that whether the call is handled by alternative response with STAR or co-responders, then there's a warm handoff and outreach from the case managers. So hopefully we can have that better outcome, right? The only thing better than de-escalating a crisis call is preventing a crisis call. And so that's where that warm handoff of the case managers takes place, that hopefully Paul can get the support moving on, and it's not just somebody calling on Paul. And then lastly, I'm sorry to sneak this in there, but I also want to point to the progress. And one of the most influential or the greatest pieces of progress that I've seen is 988. It took 60 years for 911 to reach across the country and become that go-to number for emergencies. 988 has only been in place about 2.5 years. And really, if from the intake, if Paul is in crisis and that call goes to when we're talking about the right response, we need the right response when somebody's answering that phone, so they can say, hey, this is nonviolent, we can de-escalate it X, Y, or Z. So to me, the biggest innovation that has taken place, or one of many innovations that we should really point to and be proud of, is 988 and the use of 988 moving forward.
Thank you,
Can I
Paul.
jump on
Pinkey,
there too, just for this 988 one, Paul, that
Go ahead.
our listening audience really needs to understand that the current administration, though, is cutting the funding for a particular part of the 988 for people who are LGBTQIA+, who are teens and suicidal. So we can herald these things, but we need to leverage our collective voices so that we can help those people who don't have the ability to elevate their voice and who are going to be severely impacted. So yes, it's really important, but we need not forget the attacks that are on that system, because who we believe has the right to use it is going to be important.
Thank you, Dr. Brackney. Yes.
Pinkey, go ahead.
Yeah, that's an incredibly important point. And I was over here shaking my head as you were talking, because we are completely under attack by our own administration when it comes to services that are going to be available to us in the future. And I know with the Affordable Care Act, we saw some progress. We saw the opportunity to expand some of these services into communities and to have resources to put together some incredible models that all of you have talked about, that you've created, you've been a part of. So yes, we are totally in need of our voices to Congress and to anyone that we can appeal to, that we're in crisis mode.
Thank you for that. Let me get in one more question. And my apologies to Joe if I don't get to you, but this is from Megan. What advice, and I'm gonna throw this to you, Sylvia, because you're in that track already. What advice would you give an officer on how to learn, understand, and better serve an individual who is experiencing mental health crisis? What training resources would you suggest? And you've already suggested a few. If you have anything else you want to add to that.
Yeah, I would say there are a couple searches you can do. One is mindfulbadge.com. Lieutenant Richard Geerling has committed his life to this very work. And I would say start with self and how you engage with others. There's CIT training that is robust and out there. I would also say two other clicks that are really important, or searches you could do, is University of California at San Diego, 720-degree health. They are examining the entire human being that is a police officer. And that will give you some great tools. And always the Bureau of Justice Assistance. Anyone in this conversation should go to bja.gov/PMHC. That is the Police Mental Health Collaboration Toolkit that has robust content for any of us exploring this space. So if you're going to do searches, I would say mindfulbadge.com, Bureau of Justice Assistance, University of California, San Diego Health. And then you could always reach out to the Marin County Sheriff's Office and we will direct you, or UVA and this incredible team. I have to say, before I get muted again, Paul Pazen has been just a trailblazer in this space and was early to this work when others were just shaking their head like, what are you doing in Denver? And so for all the trailblazers that we've been condemned, like, this is nuts, it'll go nowhere, we are doing the work that serves people. We are inserting humanity, and this is absolutely essential. I appreciate this question because you're taking this on. Our person who asked this question, you want to know more for you as you engage in policing broadly. So bravo.
Awesome. And Sylvia, I'm going to take your last statement as your final reflection. So it's not that I'm not ignoring you. I'm going to move on, though, to Pinkey. Any last reflections that you would like to have the audience before we hop? Time always goes so fast.
Yes, it does. Well, I'm excited for what's to come in the future. I'm glad that there are discussions like this. I'm glad that there is an awareness among us. Sometimes it feels as though no one is paying attention, But the conversation today has made me feel a lot more comfortable that people are out there advocating, people are actually creating programs, and that this is an area that we still need to continue to work in.
Thank you. Dr. B.
So yes, I'm just going to give you a quick what you can do, right? Everyone worries about, we always respond after the fact, once the 911 call is made. The one thing that we did in Charlottesville is I looked at the 911 calls to see who were the heavy consumers of 911 under our mental health. And what we did is we started reaching out to them in advance to check in often on them, to find out what was happening in advance. And you know, it's interesting how responsive people are when you determine in advance. Most people are calling in the middle of the night in crises and things like that. The other thing I would also suggest is this: go to find, you know, where the populations exist. Instead of showing up at a lot of the homeless encampment areas to get rid of them, go there in advance with mental health preparation. You know they're going to be heavy consumers of the system, heavy users of the system. Do some pre-work and not wait till the person dials 911. Get in front of the problem. That way you don't have them when they're in an ultimate crisis. You're already starting to build relationships with them. They know you're not there to arrest them. They know you're there to serve them. And it really does change the dynamics when 911 is finally called.
Thank you, Richard.
Thanks. Two quick final thoughts. One is we started some work around familiar faces, which is speaks to what Dr. B was just talking about, identifying people who are frequent users and being proactive about bringing cross-agency, multi-stakeholder kind of conversations together about how to address those preemptively. The other thing I just wanted to highlight is that with the introduction of 911 alternatives and 988, this is an equity issue. PSAPs, 911 call centers that primarily serve Black and Brown populations are less likely to have specialized training in mental health, less likely to have robust alternative responses available to them, and less likely to have even consultation available to them. It was one of the reasons we in the district were particularly happy to be expanding into wards 7 and 8 for our co-response program.
Thank you, Paul.
I just want to say thank you. It's an honor to be with you and the rest of the panelists. I'm so glad we're having these conversations. I do want to point that 10 years ago these conversations wouldn't exist at all. There's a lot more work to do. I'm not saying that we have reached our destination. This is a journey. The journey should focus on better outcomes for individuals in crisis, and if we keep that centered, we're going to be successful. So thank you to University of Virginia for hosting this and allowing me to participate with all of you. Thank you.
Thank you all. I appreciate it. And as I always say, time goes so fast, especially when we have the level of expertise we have on this call and experience in regards to how do you respond and what does the future hold for all of us, and especially those who are suffering from mental health. To the audience who's stuck with us and who is still watching, thank you so much.